Welcome, listeners, parents, nonies, papas, bubbies, and zadies, anybody who helps care for and raise a child. This is the Owner's Manual, a podcast for parents. I'm your host, Drew Nash. We have yet another terrific show lined up for you today, full of fascinating information and insights relevant to raising a child in this modern world. Today I traveled to Flourish in Danville to interview Dr. Ozzie Jafarnia, a pediatric dentist with decades of experience caring for the oral health of babies and children. Dr. Ozzie, as she's known in the community, recently started her Flourish program as a separate part of her dental and orthodontic practice. The Flourish program addresses airway issues in children and has interventions designed to begin as early as the newborn period. All of this is designed to address the size of the child's airway in hopes of helping prevent the issues that we discussed a few episodes ago when we dug deep into the topic of sleep disorders in children. As we discussed previously, the vital factors necessary for a child to grow and develop to their fullest potential is good nutrition and good sleep. You can't have one without the other. A child's brain and body need to be nourished with high-quality fuel, but also the brain and body need restorative sleep to grow, learn, and develop to its fullest potential. Before we get into the main part of the show, we have a few other items. First, the boring disclaimer. While we hope that listeners are able to learn and benefit from the content of this show, the information discussed on the Owner's Manual is not intended to diagnose or treat any specific individuals or conditions. There is no substitute for direct patient care from a trained clinician, and if you have concerns about your child, we recommend that you make an appointment with your child's primary care doctor for an evaluation. Now that we've gotten that out of the way, it's time to have some fun with Pediatric Fun Facts. Pediatric Fun Facts. Has your kid ever had strep throat or another strep infection? They're pretty common. I see it several times a day in my office. But did you know that a sudden onset of anxiety, behavioral problems, or even motor tics can be triggered by certain strep infections? Well, it's true. There's an entity called PANDAS. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Streptococcal Infections. It's a bit controversial, but it's becoming more widely recognized. This was described around 20 years ago for the first time and was more common on the East Coast of the U.S. Children would develop a sudden onset and usually fairly explosive behavior change, an onset of motor tics that seemed to be associated with certain streptococcal infections, or at least elevations of a blood titer known as an ASO titer. It's associated with strep infections. Sometimes the child will appear sick with strep throat or a sinus infection or something that's fairly common in pediatrics. Other times the infection is not so obvious and is only found by looking more closely, by doing some blood tests to confirm. Generally, once the infection is identified and treated, symptoms will slowly start to improve. They sometimes will completely resolve, but oftentimes they'll just decrease to a certain baseline, only to worsen again if and when the child gets another type of strep-associated infection. Now, the theory is that when an individual is fighting off a Group A Strep infection and they make antibodies against that bacteria, some of these antibodies may cross-react, meaning that they're not only attacking the bacteria, but also may cause inflammation in certain parts of the brain. This irritation can then trigger the onset of behavioral, anxiety, or OCD symptoms. From an academic standpoint, in order to establish a diagnosis of PANDAS, there should be a clear association between worsening ASO or strep titers and worsening symptoms. This is not always the case, however. PANS, a similar type of immune-mediated syndrome, may cause similar sudden onset of symptoms associated with other types of infections that are not specifically Group A Strep. This can be a bit trickier in that there aren't always tests to correlate onset of severity with onset of infection and onset of symptoms. The initial treatment for PANDAS and PANS is obviously treating the underlying infection. In more severe cases, use of IVIG or intravenous immunoglobulin may be used to help block and neutralize the antibodies causing the problem. Psychological interventions such as cognitive behavioral therapy are also usually employed to help these symptoms in a more traditional manner. Again, this isn't terribly common. I usually only see a few cases a year that I suspect of this. It often will come in clusters, where I'll see patients within a few weeks of each other that I suspect of having PANS or PANDAS, and then not see another one for a year or more. This is likely because there are certain strains of bacteria or viruses in the community that may have the propensity to cause these symptoms in certain kids and not others. However, if your child, or a child of someone you know, has experienced a sudden and marked onset of motor tics, OCD, or other behavioral problems that seem to be absent previously, it's definitely worth bringing this up to the child's healthcare provider for a discussion, an examination, and possibly some blood work. And that's your Pediatric Fun Fact for the day. And now a word from today's sponsor.
Are you tired of dragging your child out to urgent care when they're sick, only to have to wait in a room full of other sick people? Is it hard to find a time in your schedule that works to have your child seen? Doesn't it seem that every time you call for an urgent care appointment, you're told that there are no more appointments available? Of course you are. Well, now here's an alternative. House Call for Kids. House Call for Kids is a telehealth-based urgent care for children and young adults who are located in California. If you go to housecallforkids.com right now, you can click on the Schedule tab and see what appointments are available today, tomorrow, or any day in the next 2 weeks. All you have to do is click on the time that works for your schedule. Then you'll be asked to pay a quick deposit to hold the appointment, and then done. For your child's first visit, there are a few forms to complete online before the appointment, but that's it. Any prescriptions will be sent to your pharmacy of choice at the end of the visit. Labs and x-rays can be ordered too, if needed. Of course, there are some kinds of things that aren't appropriate for telehealth, lacerations, possible fractures, and so on. But surprisingly, most pediatric ailments can be managed through a telemedicine visit. So whether it's an acute illness with fever, a rash or pink eye, or even a behavioral or feeding question, why wait in long lines with other sick people when you can receive quality, experienced pediatric care from the comfort of your home? Housecallforkids.com. We are here when you need us.
And now, back to the show. Dr. Ozzie has been practicing pediatric dentistry in Danville for over 20 years. She has a busy, well-regarded practice that provides both dentistry and orthodontic services to children. A few years ago, she opened a separate office in the same building as her existing practice that solely focuses on issues of airway in children from infancy through adolescence. I got to take a tour of her facility and was blown away by what she's doing there. I hope that everybody listening is able to learn as much as I did from this in-depth conversation that digs even deeper into the topics we've been exploring over the past few episodes. The red light is on.
Oh my gosh.
Okay, so I am here with Dr. Ozzie Jafarnia, and you go by Dr. Ozzie, as everyone knows you by Dr. Ozzie. And she is a pediatric dentist, and we're here to talk about pediatric dentistry issues, but specifically we're here to talk about a program she started. How long ago? Like 2 years ago did you start this?
Almost 2 years
It's
ago.
called the Flourish program, and this ties in so well with what we've been talking about in the last few episodes of the podcast as far as airway and breathing. So why don't we start with you just kind of giving me a little bit of your background, just how you ended up being a pediatric dentist. You don't need to spend too much time on that. But then I want to segue into how you got into this Flourish Airway thing, and then we'll dig deep about what it's all about.
You got it. Thank you so much for having me. I think this is such an important topic, so I'm really excited to do this.
I completely agree. It's good to get the word out.
Thank you. I became a pediatric dentist when but prior to starting dental school, I was a substitute teacher for a year. And I loved it. I loved the young kids. I loved the energy that they provided. And when I went to dental school, I really didn't go in with any intention of becoming a pediatric dentist, but I loved my time in the pediatric clinic.
So that wasn't your intent initially?
It wasn't. It wasn't. I loved it. And so that kind of just took me to pediatric residency. And here we are 21 years later. Mm-hmm. It's crazy to think that I've been practicing for that long, but
you're just a
It's
baby.
been a journey. It's been a journey, and I love it. I love working with young kids. I love seeing them transition into adolescence. And I was so scared initially with, the thought of teenagers in the practice because I didn't have teenagers. And then you just see that they all bring a pretty beautiful energy themselves.
Yes.
Yeah. And I love working with parents and caregivers.
It is a challenge in pediatrics because you're not necessarily interfacing only with the patient. It's
Correct.
mostly with the parents.
Yes. Yeah. And sometimes parents come in with their own fears. So seeing that their child can be cared for in a way that maybe they weren't cared for when they were younger is pretty neat.
Yes. I have a pretty strong aversion to dentists. And I've had some really good ones over the last, years, but when I was a child, and in fact, I saw a pediatric dentist when I was a kid, but the experience was not pleasant for me.
Yeah. And so sometimes parents come in very anxious and they're trying really hard not to share that energy with their kids, but you can feel it. You can feel that they're really struggling. Yep. Yeah. So we work really hard to create a magical experience for the kids.
Great. And you have a pretty big practice here in Danville. You probably see a third to half of my patients. I mean, it's just, it's Dr. Ozzie is
so
the,
much. Thank you.
Rocket, so that's great.
Thank you.
So tell me
Appreciate that.
about the airway and Flourish and how you started digging into this.
Sure. So as a pediatric dentist over the years, we just saw trends, and you start to question it a little bit more and more with each passing year. So in dental school, we were taught so much, but at the end of the day, between dental school and residency, we have so many things to focus on. And there were things that we just didn't learn. And, teeth grinding, for example, you would see these little ones with ground down teeth and you would just say, no, this is quite normal. They're teething, or they are about to lose teeth, etc. And then over time, you're like, wow, this is really weird. Like they have little nubbins for teeth. And from there, you start to see acid reflux on teeth and this crazy erosion.
Yeah.
And then more and more, you're seeing kids on medicine for ADD and ADHD, and they're on anxiety medicines, younger and younger. And then you'd have these kids with really lovely parents that are really careful with their diets and their oral hygiene. You're like, why does this child continue to get cavities? It doesn't make any sense.
Yep.
So from there, you're starting to question. And then I think so many of us that are in this space, it happens very organically because we have a child or a loved one that is experiencing some sort of distress. So my middle daughter, I have 3 girls, and my middle one about 10 years ago or so was really struggling with sleep. She did not sleep well. She thrashed around a lot in her sleep. She wasn't snoring. She wasn't mouth breathing. But man,
she's one of those active, sweaty sleepers.
Sweaty sleepers. And she'd wake up with dark circles under her eyes. And so once I kind of went down the road of trying to figure out her sleep and going through ENT and sleep studies and working with the neurologist, like we were trying so hard to figure it out. And for her, it really came down to a vitamin deficiency. It's crazy. But so that kind of started leading me down this road. And then I became involved with the Breathe Institute. And from there, it's just been a deep, dark rabbit hole that I've entered. And I love it.
Yeah.
But the more I learn, the more I realize I don't know. And I still have so much to learn. And I think that's the beauty of any of us in our professions. It's a constant learning experience for us. And I think with that learning, we bring better objectives to our patients and practices.
So your Flourish practice, you have it's in the same building as your main pediatric dentistry practice, but it's a completely separate office.
It is.
So tell me what you do here, what ages you start looking at these kids, and what you do for them at different ages.
Sure. So when I originally I would do tongue tie releases with a scalpel because that's how I was trained. And then when I learned about CO2 lasers.
And you're talking about babies.
For infants. And at that time, and we also were taught that tongue ties don't affect speech. They don't have any relevance to speech and articulation issues. So I would only really treat babies only when a parent was an established parent of our practice. And then at some point I started learning more about CO2 lasers. And so I would refer all of those children out because I felt like if there was a better way of them being cared for, they deserve the best care. So once I started learning more about CO2 lasers, about tongue tie releases and the impact that it could have downstream, then I wanted to be able to provide that, but it was really hard to fit that into a normal pediatric practice.
Because you're busy.
Because we're busy and we have time. Yeah, it takes time, and you really want. It's a parent with a newborn. You want to be able to have a really nice, calm conversation. So that's sort of how Flourish developed. We had the opportunity to move within our building and create this space that we really cherish, and we practice very, very differently than we do upstairs.
And it's amazing. You gave me a tour. It's a beautiful space. It's very calm in here.
Thank you.
And it's funny because my office is usually not very calm. Someone came in yesterday and said, is it always this noisy here? Mm-hmm.
Yeah.
Yep. Toddlers.
Yeah,
So,
exactly.
but it's very calm here and soothing, and it's just a separate space, so you don't have the regular volume of the pediatric dentist patients coming through.
Yeah. So what we can talk about in a half an hour, 45-minute clinic appointment upstairs, we have a lot to talk about in and of itself, right?
Sure.
And so then this gives us an opportunity to really spend time and dive deep into airway issues and sleep, et cetera.
So how does it present itself? How does the patient end up here?
So if it's an infant, oftentimes it is a lactation consultant that will refer them over, or a chiropractor, someone that has been caring for the baby. If it's a first-time mom, if it's a second time or subsequent mom, then they usually are a little bit more attuned to what is going on with their nursing journey.
Yep.
And so they will self-refer. But for the babies, oftentimes there's just challenges and they can't figure out what's happening. So even if a mom calls our practice to set up an appointment and it's a first-time mom, then we'll ask them to please see a lactation consultant first.
If they haven't already done that.
If they haven't already done that, because it is so much more than just a tongue tie.
Yep.
You know, a lot of times these kids have a lot of tension in their bodies. And so we want to do releases when it's appropriate, but it's a very collaborative process. So that's part of Flourish. It's an airway collaborative because we really need to work with other specialties very closely.
Sure.
Yeah. So
you see them as early as the first week, if that's appropriate.
As early as the first week, if that's appropriate. And then we see kids all the way through about age 7 or so.
Okay.
So we're doing, we do a lot of tethered tissue releases. And then also once you start learning about tethered tissues and tongue posture and where the tongue belongs in the mouth, it's about tongue space.
So where does the tongue belong in the mouth?
The tongue belongs at the roof of the mouth, lightly suctioned to your palate.
Which is not what I used to think. And I think I mentioned previously in one of my podcasts that I went through some myofunctional therapy. So it doesn't belong at the bottom.
Nope, it belongs
that's
at the
a
top.
problem.
Yes, yeah. And, you know, it's funny. We have these conversations with parents all the time. And we'll say, okay, well, your child's tongue belongs in the roof of their mouth. And the parents have this like very puzzled look all of a sudden.
It's not intuitive.
No. And so they're like, wait, hold on a second. What do you mean? You know, it's not something that we spend time paying attention to. And then once I tell them that, it's kind of hard because they're put on the spot. So I'll explain, just drive home. And while you're driving, if you're not talking, you're not eating, just kind of notice where your tongue is.
Yeah. And where should it be?
And it should be at the roof of your mouth.
So,
yeah.
Right behind the teeth.
Right. Yeah.
On the hard palate.
Correct.
Kind of touching there. And my wife used to tell me, tip to the spot.
Exactly.
Yeah.
Which produces a lot of calming, it's a vagal response. It calms your body down without you realizing it. And so we see, once I began this journey, you realize, wow, these kids that are really hooked on a pacifier, they're really hooked on their thumbs. It's because they're trying to emulate what their tongue is supposed to be doing.
Oh, interesting. So they're trying to stimulate the roof of their mouth with either a finger, thumb, or a pacifier.
Yes.
Okay.
Right? Because their tongue is sitting low to their mouth. And so they don't have that natural stimulation. So they're producing it.
That's fascinating. I had not heard that before. That's
I know.
See, I learn things every time I do this.
I'm
great.
still learning. I know. It's very cool.
So if a parent is observing their child or themselves, and their child is sitting there with the tongue kind of hanging out the front a little bit or down at the bottom,
yes,
that is not normal.
that is not normal.
It is not normal.
No.
And so what does that cause? What are the repercussions of having a low tongue posture?
Sure. So when we think about low tongue posture, we're thinking about it. Is it from a tether? Is it from a pull on the floor of the tongue that is really creating that restriction? Sometimes it's low muscle tone. And it doesn't have to be that you're low muscle tone throughout your body, but it's just low muscle tone in your mouth.
In your mouth, yeah.
Or it's habitual, right? Like you have a child that has caught a cold, they start breathing from their mouth and they sort of forget. And so they just keep their tongue low to their mouth. But that tongue posture is so important for palatal development. So the tongue is really your natural palate expander. So if your tongue stays in the roof of your mouth, it creates its beautiful arch form. And from there, it keeps the floor, the roof of your mouth is the floor of your nose. So the wider your palate is, the wider the internal passage of your nose is.
Everything is wider up top.
Everything is wider up top.
And so just to be clear, the the palate forms around the tongue.
Correct.
And if the tongue isn't there,
correct,
then the palate is going to be just narrow as it can get away with.
Yes. And so the problem with that is that you'll have this palate that becomes narrow, but it shrinks and it takes the bottom teeth with it.
Yeah.
So then you have top and bottom crowding. Sometimes we think of a crossbite, but it's not as common as you think to see a crossbite. It's more that both upper and lower jaws shrink. So where we used to just look at crowding and say, okay, you're going to need orthodontics, but if you're functionally looking at it, like why did the crowding happen to begin with? There's usually an oral motor aspect to it. There's oral dysfunction that has played into that significant crowding.
Yeah.
Yeah. So you'll have kids where if they have low tongue posture, it's kind of interesting. Sometimes their lower teeth are super spaced, but the top is really shrunk down.
So the lower teeth are spaced because the tongue is sitting there.
When it's super low, like especially if they have a tongue tie, like the bottom arch can look really perfect, but the top is really tiny.
And then eventually, as the face grows,
yes,
and the top stays narrow, then the bottom isn't going to be as wide looking as it looks initially.
Correct.
As it follows the top.
Correct. But that, having the tongue up to the roof of your mouth is what drives forward facial growth. And the more forward your face grows, not only is it aesthetically much more beautiful, the airway is bigger.
Right.
So if you have a child that's a chronic mouth breather, their tongue is positioned low, their mandible is going to kind of drop down and backwards. And so that's going to restrict your airway. And then you have like a longer face. You have sometimes droopier eyes, the inside of your nose shrinks.
So tongue low.
Yes.
The top palate isn't as big.
Correct.
It's more narrow. What happens is your jaw doesn't grow as forward.
Correct.
So your tongue is more posterior.
Yes.
Backwards.
Yes.
Your airway ends up being smaller.
Yep.
Your nose, you said, because the nose width follows the palate on the top.
Yes.
That's more narrow.
Correct.
So you end up with a kid who really doesn't have as much room for airflow.
Yes. Yes.
And that's what we're talking about here.
Correct. Yes.
Yep.
And so this vicious cycle starts, right? And so if we can, our goal is to intervene as early as humanly possible.
Sure, because the sooner you stop that process,
yes,
the sooner you're fixing it.
Yeah. Because then as an adult, we have compensation. So we have compensatory patterns. We've gotten used to it. But kids are malleable. They're young. They're squishy. So you can make a big difference with very minimal interventions if you can catch them early enough.
Right.
So
you're talking about compensatory patterns in adults. So what do they do? How do they compensate? I mean, I know people snore and they get CPAPs, but
sure.
But
But sometimes we carry a lot of tension in our necks, which ends up holding, will cause TMJ issues and clenching and grinding, and then you'll have neck, compensatory patterns. There's so much, but as an adult, trying to do an expander is not super easy. Right?
Yeah.
There's different methods of expansion, and some people believe that you can do it without a bone-borne expanders, but bone-borne expanders are becoming more and more popular. But that requires an implanted expander, which
is a big deal.
Just a big deal compared to what we're doing with kids. And especially if you can get to a baby, a toddler, their tongue just needs to be in the right spot. Like that is their version of an expander. It doesn't get more natural than that.
And how do you accomplish that?
So that's working with teams, right? It's working with an oral motor therapist. It's working with the lactation consultant. It's working with a myofunctional therapist. So depending on the age of the child and kind of where they're at with their development is who we bring in to help us. Because I can identify issues and I can say I can treat a tethered tissue, but at the end of the day, I'm not an oral motor therapist. And so sometimes these kids just need to get more tone in their tongues. And that tongue tone is what's going to help them be efficient feeders, not only as a baby that's nursing or feeding from a bottle. We want those children to not take in air. We don't want them to have these really long, elaborate feeds because they're just inefficient. So that's working with the lactation consultants, right? That's working with the body workers. They can maybe reduce some of the tension that comes from the birthing process. Then as they're getting a little bit bigger, the oral motor therapists, the SLPs that have an oral motor or feeding therapy background are critical because the child that doesn't necessarily nurse or feed with a bottle efficiently is also not going to take in solids super efficiently.
Well, I mean, if you are obstructed
Yep.
and you're trying to use the same hole to eat and breathe,
Yes.
there's a lot of kind of gasping and choking, and it's
Yes.
not an efficient way to consume food.
Correct. And so then, and you know, in our environment nowadays, we have a lot of processed foods, right? So we have parents, you know, will ask them, do they like crunchier, textured foods? And sometimes their thought process is, yeah, they like to eat crackers, but crackers at the end of the day dissolve. They crush them and they dissolve in their mouth. But we're thinking about things that are a little bit more fibrous and chewy, and, you know, the carrots and the apples of the world as far as fruits, and then the meat textures. But they end up choking, they gag more. They're going to be looked at as a picky eater, but is it really that they're picky, or is it that it is so hard for them to move a bolus of food around because their tongue's not functioning properly?
Sure.
That they're avoiding things that take more effort.
So if you have a kid who's a picky eater,
Yes.
watch them eat.
Yes.
How's that going? Are they kind of chewing and gasping and trying to breathe through their mouth while they're trying to consume these more tactile foods?
Exactly. Are they pocketing it in their cheeks for long periods of time? Do they eat the meat, but then they ultimately spit it out? Do you have to cut it really, really small? And then it kind of takes away the chewing aspect. Functional chewing is so important for jaw development also.
This is something I see every day.
Do you?
And you're just, again, the more I talk to people, the deeper the rabbit hole
Yes,
gets.
it really is.
So yeah, I have a lot of patients who they come in with, you know, whether they're picky or very texture averse.
Yes.
Now I'm going to have to be
Yeah.
looking. Yeah.
Yeah. And so that's kind of what we're doing in Flourish. We have a family come in, whether it's a baby or it's a toddler. The toddlers, we're like little detectives. We're trying to go backwards in time. We start with birth, and then we kind of move forward from there, because a lot of what we're looking at in a 4-year-old started developmentally much earlier. And it just wasn't caught for whatever reason. Sometimes the mom's flow is really great, and they produced, and they didn't realize they maybe had issues because they got through it.
Yep.
We had a child last week that has the strongest tongue tie known to man. He has a grade 4 of 4. It's tongue to tip, so it's very noticeable.
The heart-shaped tongue.
The heart-shaped tongue. He can't produce. He's 6 years old. He can't produce so many sounds. Did
he nurse, or was he a bottle?
He nursed. And
See, that's crazy. That's not supposed to happen.
It's crazy. And he had come with his dad, and I told the dad, you need to go home and get your wife a big bunch of flowers, because I don't even know how she managed. He said, yeah, it was super painful for her, but she just got through it.
Yeah.
It was crazy. But this poor kiddo has been in speech therapy for 2 years.
So what the tongue is supposed to do when you're nursing, it's not, you don't suck on a boob the way that you do on a model. The tongue lifts up and elevates and is able to push the milk out of the ducts into the mouth.
Correct.
And so if your tongue is not able to lift, they're going to treat a human nipple as a plastic nipple.
Yes.
And
exactly.
That's going to be painful.
Super painful. They're going to chomp. They're going to bite. They're just trying so hard to get the milk out.
And if a baby's able to extract enough milk that way, that means they have some serious suction going on.
Yes.
Yeah.
Yes. Which is super uncomfortable.
Super uncomfortable.
Yes. Yeah.
Okay.
And then we look at lip ties. We're looking at cheek ties. And again, it's all about function. It's all about function. So I don't see a tether, treat a tether. It is there a functional deficit happening?
And that's kind of where I get into sometimes with lactation people, seeing the posterior tongue tie. Mm-hmm. So the obvious ones with the band,
yes.
I can treat in the office. It's a 10-second procedure. It's so easy.
Sure.
But then there are these kids who are still having functional issues, and the lactation people feel there's a posterior tongue tie. And I can't quite figure out how to see that as a physician.
It's actually really hard to see. You have to feel it. Mm-hmm. So it's not it's a baby. You can't ask them to lift their tongue and feel it. So you're elevating their tongue sort of on either side. Mm-hmm. And as you pull it up, you'll feel a really tight little elastic
So you feel
band.
in that what looks like normal tissue, because the tongue has to be connected to the floor of the mouth.
Correct.
You feel a tight band.
You'll feel a really tight band. Yeah. You'll feel a really tight band.
Got
and
it.
it's once you feel it, then you know it's there.
Okay.
Yeah. But those are the really tricky ones. And sometimes babies are treated and the anterior portion is taken care of, but maybe they're still symptomatic or maybe they're not. But then later, as they're developing and they're older, sometimes we'll say, okay, well, now we're noticing these are the deficits because the back of the tongue is having trouble lifting.
So I've talked in the previous episode, so speech obviously can be affected, because if you can't lift your tongue up, you can't make S's and THs.
Yeah.
And then tongue thrusts, it affects orthodonture.
Yep.
We talked about, the narrow palate and all that. So that clearly low tongue posture. And then you get into grinding and bruxism and TMJ pain as adults or even as teenagers.
And sometimes, you see kids all the time, obviously with ear infections, but our thought process is if their swallow is deficient and the back of their tongue isn't elevating the way it should, they can't clear their eustachian tubes as easily.
Interesting.
So that in combination, obviously with enlarged adenoids, can make a really big difference.
Yes. Okay.
So, kids are obviously more prone to ear infections anyways, but then you have a deficient swallow and that clearing.
So it just keeps going.
It just keeps going. It
just
keeps going.
Now, looking at your Flourish program, moving on from the newborns and the babies, the slightly older kids that you have the scanner you use.
Yes.
Can you talk a bit about the beam?
Sure. So we have a CBCT, which is cone beam computed tomography. So it gives us a 3D view into a child craniofacial development. So we're looking at, and again, I'm not a radiologist, so I take this x-ray. I know it's a super powerful image. And so I share with families what I see on the image, but I also tell them this is going to go to a professional radiography group, the beam readers group, and they will help us analyze everything down to a T.
So you do the scan here and then that gets sent off.
Correct. So the scan will show everything from their sinuses, their septum, their turbinates, all the way through to their ear canals so they can catch, wax accumulation is pretty interesting. But what we're looking at it so often, we're looking at tonsils, we're looking at adenoids. We can see tonsils two-dimensionally in the mouth, right? But I don't know how far back they go. We're looking at their airway dimensions. And then we're looking at their teeth, obviously, and how their teeth fit in their mouth, the developing teeth that are coming, how crowded they may be, where the maxilla is in relationship to the cranial base. Is it too far back and that's impinging on the airway? Can we develop them and bring them more forward? We're looking at the tongue posture. So a child doesn't know where their tongue is. But when we take this scan, it becomes very clear if it's through the roof of the mouth or if it's sitting low. So it gives us a ton of information.
How long do they have to sit still for this?
7 seconds.
7 seconds, it spins around.
Yeah.
Is it kind of like a pano?
Similar to a pano.
That kind of a thing.
Similar
so you're
to a
standing
pano.
in the little machine and it zips around your head for...
So they sit down. We have a little seat for them or a little booster seat if they're small enough. We take a scout image just to make sure that we're going to have them be able to sit still because we don't want to take an x-ray if it's not going to be feasible for them. But it gives us a ton of information. And we do reduce the radiation to the lowest amount possible. So it does make it a little bit less clear than it could be. Like this x-ray could be extremely crisp and that's what you need to be able to place an implant, for example. But for our purposes, we choose intentionally to bring that clarity down.
Absolutely.
Yeah. But it just, children, especially if they've gone to ENT and the parents have said, my child's snoring, they're struggling. The ENTs, if they can't place a scope in, it's really hard for them to see the adenoids. And so then these kids will come back or maybe they have scoped them and the parents hear that they need surgery. Sometimes it just doesn't resonate yet. Yeah. Right. And seeing it on a huge computer screen can make it a little bit more clear. And you can see the whole 3D image. It's incredible.
And you can rotate it around and it's pretty amazing.
Exactly. It's pretty amazing. So we can take the size of the baby teeth, we can measure those, we can measure the size of the permanent teeth, and really automatically know how deficient we are in spacing even.
And how young can you do this?
Depends on the kiddo. Yeah, so I'd say 3 is probably...
A 3-year-old can sit still for 7 seconds.
A 3-year-old can sit still. Most 3-year-olds.
Sure.
Yeah. It's very different than taking intraoral x-ray. So intraoral x-rays, a 3-year-old we still try to take them when it's appropriate and they have contacting teeth. But it's hard. It's hard to keep a sensor in your mouth, especially for a child that's having trouble breathing. Yeah. And again, we didn't look at this that way before. We were looking at a child like a 4, 5, 6-year-old that's struggling with x-rays. But why are they struggling so much? Because oftentimes they can't breathe. And so when you have things placed in your mouth and you're a mouth breather,
it's hard to
you feel like you're suffocating.
Sure.
Yeah.
Yeah.
But this x-ray, they just sit down and it just quickly scans them and it just gives us a ton of information.
And then what's the intervention if we determine that they're having, narrow, they have a high arch palate.
Sure.
And they're having mouth breathing. issues, and what do you do?
Yeah. So we're looking at it in many different ways, right? So sometimes we take this x-ray and we see, oh my gosh, their sinuses are full. They're constantly congested. Their adenoids are massive. Their tonsils might be really large. Say you have the child that doesn't have enlarged tonsils and you see that their nasal passage is pretty narrow. Their arch is really tiny. If that's a child that can tolerate it, then we start early expansion. So expansion is a method where we're taking that mid-palatal suture that's still very pliable in a young child, and we're putting tension on it with an expander.
So sutures where the bones are meeting, but they haven't fully connected yet permanently.
Correct. So in the middle of your palate on the top, like if in the roof of your mouth, that suture is still very pliable at a young age. As time goes on, it becomes more interdigitated, and so it becomes more and more challenging and more noticeable by a child as you try to put tension on it. But in young children, it's very feasible to kind of put tension on it and grow the palate.
And it widens out pretty quickly.
It widens out very quickly. We also don't want it to grow too quickly because we don't need that. We don't need to put a ton of tension on it, but it's just an appropriate amount so that way it grows and it widens it width. It creates a broader nasal floor, and in return, it creates a lot more space for the tongue to be able to fit into the roof of their mouth.
So say you have a 3-year-old or a 4-year-old, which is pretty early expansion compared to what traditionally has been done.
Yep.
What's the time frame that they have that thing in their mouth and that they're expanding? Is it a 3 to 6 month thing? Is it a 1 to 2 year thing?
Sure. Good question. So generally we're expanding because we're doing it so slowly. We're expanding for about 3 months. Mm-hmm. So it takes about 3 months to get to the full width of our expander.
Which isn't a lot of time.
It's not. And then typically after that, we're holding them between 4 and 6 months, depending on the age of the child. But it's
you keep it in, but you're not turning the key.
Correct. We're just waiting for the bone to sort of settle. Mm-hmm. And then afterwards, it's very different practices. Some give retainers, some don't. In our practice, we do give retainers, and we don't want to give them retainers indefinitely, right? We just want the retainers in there long enough that they can begin their myofunctional therapy and really so at the end of this process, my goal is that these children are sleeping with their lips sealed, mouth closed, tongue to the roof of their mouth, breathing effortlessly.
And that is normal.
That is normal.
That is what a person should do.
Yes. We want kids to be silent and still.
Yep.
And I think we've normalized dysfunction a lot of times in kids. I think parents are like, they snore.
Well, one of the things that Dr. Takar said in her podcast that she finds very frustrating is parents come in and think that their kid's snoring is cute.
Yes.
And whether you want to judge it as cute or not, it's not normal. It is not normal to make that noise when you are sleeping.
Correct.
Yeah.
Correct.
And that indicates that there's an airway narrowing or an airway compromise.
Right. And, sometimes parents will say, like, I snore, my husband snores. And, I can hear my child down the hall, and it's like a familial thing. But I want to just cry and just say that all of you guys are not sleeping well.
Exactly. Right. That's you all are having a sleep problem.
Yes.
And that's not good. We need to break the cycle.
Yeah. And then sometimes, the mouth tells us so much about a child. And so we had a kiddo recently and her mouth is teeny tiny and she sounds congested. And I'm talking to the mom and, we take her x-ray and her x-ray does have enlarged adenoids, like massively enlarged adenoids. And so when you're talking to her, she's like, well, she doesn't really snore, but then you're worried, like, is she having apneic episodes?
Right. She's just not breathing.
She's just not breathing.
You have to move air to make snoring noises.
Yeah.
And if you're not, then you're not going to,
Exactly. And then they say, they wake up every night, but they've woken up every night since they were born. But you have a 5 or 6 year old, that's not normal anymore.
Yeah. And that's what Dr. Takar said. Waking up throughout the night is not a normal thing.
Yes.
I mean, when you're a baby and you're nursing, of course you're hungry.
For sure.
But for a school-age kid, it is not normal to wake up at night.
No.
And one of the things we talked about before, which I just now have been kind of reflecting on, is remembering what it was like to sleep as like a 7-year-old, where you close your eyes and you open your eyes and it's the morning. It's like a blink.
Yes.
Because you're out. There's no tossing and turning like we do as adults because our hips hurt and our neck hurts. It's just you lay in bed, you close your eyes, and then all of a sudden the sun is shining. And that is what a kid should experience.
Right. Right. And that restorative sleep is also, it's going to give you the best impact in terms of your learning and
growth. And development and behavior and all the things that everything. It's everything.
Yeah. We want kids to be the best potential of themselves. We want them to be the best version of themselves. And if they're not sleeping well, there's going to be impacts. Maybe not immediately, but the impacts follow, right?
Long term.
Long term.
So then you're an adult who needs CPAP because you can't breathe. And you can prevent those things. You can intervene and make that not the case when they're adults.
For sure. And I know, sometimes like families initially will think like, wow, like that seems really early. We're not trying to fix teeth. I'm not here to make an aesthetic smile. I'm not starting orthodontic therapy in a young child because I want their teeth to look better. I'm doing it for functional reasons. Yeah. Right? We're trying to expand the bone because at the end of the day, our mouths are our mouths. And so either you're going to stretch it and make room or you're going to extract teeth to make room. And so if you're extracting teeth, you're just making that space smaller for the tongue.
You're making the teeth look better, but you're not fixing the problem.
Correct. Yeah.
And so, sleep and nutrition are the two things you need to grow and develop. And so if I told a parent, sure, just give them potato chips for 3 meals a day, they look at me like, well, that's not good.
Right.
And you can get the calories in,
Yep.
but it's not good for you. You're not going to reach your growth potential. You're not going to develop right. And the analogy is pretty clear cut. It's the same thing.
Great.
You need to have restorative sleep. You need to be able to breathe comfortably, get oxygen to your brain 24 hours a day. It's the same thing.
Right. And I think sometimes some parents are super aware. They've gone on vacation and they've sort of noticed it, or a sibling is in the same room and the sibling has noticed it. But, we ask families when we see the clues and the parents don't really notice them, we ask that they check their child at various time points throughout the night. Yeah. Just for a few nights, just to really see. Otherwise, a sleep study is definitely indicated.
And there's an app you can get. I don't know what it's called, but I know people who have used it. There's an app you can get on your phone that basically you turn it on when you go to bed. And I had people use it because sometimes they talk in their sleep and they want to hear what they say.
Oh, funny.
But it records noises, and it doesn't record all night. It's just, it kicks
Snore
in.
Lab?
And I'm sure there's several.
Sure.
But you turn it on, and so if your child is sleeping quietly all night long, it's not going to record anything. Right. But it'll record all the events, whether it's a sleep talking or whether it's snoring and gasping. And so that's an easy, cheap way
for sure
to just get a baseline. Is my kid making noise when I'm not standing in the doorway?
Right. Yeah. Right. And I think parents sometimes, we have a child sleeping. You don't want to go in that room and wake a sleeping bear. You're like totally happy that they're in their room. Yeah. But the reality is if they have all these micro arousals throughout the night, whether or not you realize it,
it's not normal.
It's not normal.
Yeah.
And it's going to have, they're going to be dysregulated. They're going to be emotional. They're going to have outbursts. As adults, we might be able to hold it in when we're tired and we can just be exhausted. Children sometimes are super hyperactive and fidgety, and they're like, they're fighting with their siblings more than they typically would.
And then we try to send them to school and tell them to learn things.
Yes.
And if you're just not restored at the end, every night, one after the other.
For sure. And then that night's sleep is where their memories are all being consolidated. So it's vital. It's vital. And I feel like this is a very different experience than when we were upstairs in the pediatric department. We are having a lot of diet and oral hygiene counseling, and we're trying to prevent issues from one aspect, but this is prevention on a totally different level.
Yeah, like fundamental, right at the foundation of. Yeah. So, parent of a newborn, obviously if there's nursing issues, parent of a toddler, when should they be concerned? What are the red flags that maybe they should come see you or someone else who does what you do?
Sure. I think that the red flags that I would be looking at are really that they have trouble breathing from their nose. I think nasal breathing, we were talking earlier, really trumps everything. So if you are constantly trying to suction their nose and you notice that they cannot breathe from their nose, that is concerning. Talk to your pediatrician, go to an ENT, see an airway dentist. So the mouth breathing, and number one.
Not all dentists are
correct
on board with this. Right. It's sort of an evolving thing.
Right.
So not to diss anyone, but you need to find someone who is really oriented towards looking at airways.
Very true. Yeah. Very true. This is not something that we were just chatting. This is not something we learned in dental school. This is a lot of hours of continuing ed because I'm interested in it. And there's others that are very interested in it. So definitely finding the providers out there. And it's a pretty big connection. So if there's ever questions about that, I'm happy to point parents in the right way.
If a kid's sitting there, mouth breathing, they have their mouth open, their tongue's kind of hanging out. Not normal.
Not normal. And so
what if they normally breathe through their nose, but they're sick with a cold?
Sure. That's different.
Like for a week they do it, but most of the time they're fine.
Correct.
That's different.
That's different.
And you could then do as much as you can to keep their nose clear while they have the cold.
Yes. Yes. So saline rinses, Xlear, things of that nature. But sometimes, you'll ask a parent, okay, well, they sound like they have a cold or they're congested. How often has this been happening? And they're like, oh, it's allergy season. But if that allergy season is not a season and it's just all year long, that's a problem.
Yeah.
Right. So you want impact of sleep disordered breathing, like snoring 3 times a week is going to add up.
Or even if you truly are just having seasonal allergies that it's 3 months out of the year where you can't breathe through your nose, something needs to be done. And that might be getting more aggressive with treating the allergies.
Correct.
But you really need to make sure that the air can go through the nose holes.
Exactly. At the end
That's
of the
what
day,
it's there
this
for.
is what it's there for. Yeah. So you have a child that's mouth breathing, they're waking up, their sheets are a mess. They wake up, their hair is like a little, like a rat's nest. Those are things that we say are kind of good indicators that they did not sleep well the night before. They're sitting there, they're watching, they're playing a video game, their tongue is their mouth is open. So at rest, your lips should always be sealed and you should be effortlessly breathing from your nose. So that lip seal is very telling, right? And sometimes parents think mouth breathing, they have to look like Napoleon Dynamite, like their mouth has to really be gaping open. It's not always like that, right? And so, but it can still be very impactful. So those are the things. You're looking at how they're eating and how they're chewing and swallowing. Are they a super messy eater? Do they hate eating certain foods? But if they're a messy eater, sometimes it's because they can't close their lips.
Because they're chewing with their mouth open because it's just like chew, breathe, chew.
Yes.
Yeah.
Yeah. And then for the kids, when we're thinking also going back to their sleep, are they sleeping on their stomach all the time? Because that's a compensation to keep the tongue out of the mouth.
Oh, interesting.
Yeah. So if they're on their back and they don't have that lightly suctioned tongue to their palate, when they're in REM sleep in particular and their body's sort of in a more paralyzed state, their tongue will fall back. So then they're going to arouse.
Choose to sleep on their belly.
They choose to sleep on their belly. Or
There's someone who sleeps on their belly occasionally, but if someone's really a belly sleeper, that's a primary.
Compensation.
Yeah. Okay.
Yeah. So, you're looking at that. You're looking at their teeth. Are they really ground down? Are you hearing that when you go to the dental practice? Are they saying there's a lot of acid erosion?
I wanted to touch base on that.
Yeah.
So acid reflux. And this happens probably twice a year. I'll have a patient who comes in because the dentist sent them to me.
Yep.
And it's nice when they had a previous visit where it was noted that there wasn't acid erosion. And then they come in because there's now significant.
Yes.
So what's at play here?
Yeah. So if they're working extra hard to breathe and there's enough airway resistance, sometimes that intrathoracic pressure will pull acidity up.
So when you're pulling in to breathe because your nose is blocked, you're sucking.
Yeah.
And it doesn't just suck air from the outside,
Correct.
it sucks air and whatever's in the stomach up.
Yeah. And so these kids, you'll see big craters on the biting surfaces of their teeth. And sometimes it also lends itself to cavities because at the end of the day, cavities are happening from acid production.
Sure.
So if that acid is just hitting between your teeth.
Degrading the enamel.
Yeah. And so it should not look that way. And so sometimes, it's not a matter of you can't produce that with diet.
Yeah.
It has to be that acid is sitting on their teeth for extended periods of time. But as adults, you and I will have heartburn. So we always will send to a pediatrician because we want you to rule out that there's no other issues happening.
And, the short-term fix is to put them on, an acid blocker. But that's a Band-Aid.
Right.
That's not fixing the problem.
Right.
You have to look at the airway.
Yeah. So I think we're just all trying to get back to the root cause of things versus treating the symptoms.
Yep.
Because before I would see ground down teeth and I'd say, okay, well, here's a mouth guard.
Yep.
Here's something to prevent further damage to your teeth, not even thinking about what could have caused the damage to begin with. Mm-hmm. And same with acid reflux, right? Like we may have put more fluoride on the teeth just to help prevent further sensitivity.
But that's the Band-Aid.
That's the Band-Aid.
Yep.
So it's really just going backwards in time. And then, the kids that have speech issues, so it's really hard. That's a sensitive one because I'm not a speech therapist, but you and I see enough children developmentally to know where things sort of land. So sometimes if a child is super intelligible and they're going to school, they're not getting pulled for speech therapy because they are meeting the criteria
Well, to get pulled for speech therapy, you need to be 2 standard deviations outside of the norm, which is pretty far.
Yeah.
That is, for a school-age kid, they have to really have intelligibility, or that's the word.
Yeah.
They need to be unintelligible.
Yeah.
Be hard to understand.
Correct.
In order to qualify for speech. There's plenty of kids that need speech or that have issues that don't qualify.
Right.
Yeah.
And so those are conversations I try to have with families where the child isn't there because I don't want them to become self-conscious of it themselves. But we'll kind of plant a seed with parents like, hey, this is what I'm noticing. Again, take it for what it is. I'm not a speech therapist. But if that tongue is working harder than it should, it can't produce and elicit all of the sounds and we want your child to be confident in their speaking. It's super important because sometimes by the time the child notices it, it's super late. And then they're embarrassed to talk around friends. And that's terrible.
Sure.
Richard Baxter, who is the author of the book Tongue Tied, actually makes a really good analogy. He said it's the equivalent of you have your shoelaces tied together. You can do it. You can run with your shoelaces tied together, but it is not easy. So sometimes these kids are working so much harder than they need to be.
Sure.
Just to produce the same sound. Yeah. So, those are things that, and if, as a parent, you kind of have a gut feeling. If something doesn't feel right, you should investigate it. Mm-hmm. Talk to your pediatrician, talk to the ENT. Allergists are very crucial in this whole cascade for sure too.
So from a newborn standpoint, obviously nursing, making sure the tongue has good mobility.
Yep.
And then you were also you showed me your baby room where you had all these nasal clearing things.
Yes.
So really focusing on nasal congestion, even for the newborn who doesn't have a cold.
Correct.
So tell me more about that.
So if we nasal breathing, and in all this coursework that I've done over the years now, it all comes down to nasal breathing.
It does.
It all comes down to
the nose is there for a reason.
The nose is
not
there
just
for
for sticking your
reason.
finger in.
Correct. Or Legos.
Yes, Legos.
But yes, it is so vital. So if you can get a baby to sleep breathing through their nose from the beginning, so many of these downstream problems will be fixed. Will not even happen, I should say.
So what do you teach these parents?
So we're asking parents to use saline if necessary. Mm-hmm. So, certainly if they're after a bath time and everything's sort of damp and loosened up, you can just use a nasal suction. But if they have congestion, and if they have older siblings, they're bringing germs home from school, really working with just a little bit of nasal saline and evacuating the nasal passages. And then when they're sleeping, really putting a little bit of pressure behind their mandible. If they notice that the mouth is open, just trying to elevate the mouth, close the mouth, and seeing that tongue is sort of pushed up against the palate is a really nice indicator that they're going to develop nicely going
So
forward.
You do that while they're sleeping, just gently to assess or to try to train?
Both.
Okay.
Both. So if you know that they can breathe nicely, you're not going to hold it for a long period.
No, but if you put
just
your hand
gently,
there and you close their mouth.
you close their mouth.
And they're continuing to breathe comfortably.
Through their nose.
Then that's good.
That's great.
And if they start fussing and sputtering because they can't,
Yeah.
then that's an indication that something needs to be looked
Correct.
at. Yeah.
Correct. Exactly. So that's definitely it for a newborn. You want to be able to put pressure on a newborn's chin when they're sleeping and kind of hear that audible, like a pop where their tongue pops down from their palate.
So you pull their jaw down, their tongue should be almost like suction to the roof of their mouth when they're sleeping.
Yeah.
And you release it, you hear that.
Yeah.
That's what you should hear.
Yeah.
See, I'm learning so much here.
Yeah.
Okay.
Yeah. Even if it's not a super audible pop, you'll just see, you'll just put pressure on a baby's tongue and you'll just see that it's elevated.
Come down.
You'll see it come down. And then and that's just for your experiment.
No.
And then you go back and you push on it again.
In the natural state
of
everything working like it should, the tongue should be sitting, what we said earlier, tip to the spot.
Tip to the spot.
Yeah.
The back of the tongue kind of just
That's
gently.
how it should sit. And if it's
mouth.
not, there's a suggestion that something else needs to be looked at.
There's going to be more of a downstream effect.
Okay.
And so if we can get to them early, and if you can notice these things early, you're going to save your child just, from other procedures that they may not need to go through. For sure.
Things early.
It's fascinating.
It is.
So with pacifiers and thumbs, I was a mom. I mean, I am a mom, but when my kids were younger, I will never forget, my second child was born and I was super sleep deprived. My practice was just opening. And I knew better than to give my child their thumb. But at some point I was rubbing her thumb against her mouth because I really wanted her. I just wanted to get through a night of sleep.
Well, you just need, anything just so I can sleep for just 2 hours. Yeah, absolutely.
but now I know better. And so, where my daughters had pacifiers till 2, now I'm asking parents to please try to take it away by 6 months, because we
6
really,
months. Okay.
and the reason for that is because we need that tongue up.
Got it.
Because the pacifier, a thumb, everything's going to artificially keep the tongue posture low.
So just to review myself, so I have been telling parents, at a certain point, you try to only give it to them in bed.
Sure.
But that's kind of the opposite of what you're saying.
Yeah.
You really want that tongue to be at the roof of the mouth
Yes.
when they're sleeping.
Yes.
And during the day when they're awake, we don't want them there anyways.
No.
So you are saying initially there's a certain amount of just self-soothing sucking that's normal.
Yeah, for sure.
But by 6
sure.
months,
Yeah. I know.
I
mean, if I have a family that's really struggling with that, then I'll just say, give it to them just for a little bit for them to fall asleep, and then you pop it out and you try to push on their, like, underneath their chin.
Okay.
Right? So just help that elevation, because the longer that pacifier is in there, the longer that tongue posture is low, when they're sucking, all of, like, their masseter muscles, everything is pushing inwards. And so it's going to even constrict the arch more.
Wow.
We used to think of it as just the front teeth. And oh my gosh, the front teeth, they can, buck out a lot and they can calm down. So no problem. You'll lose the pacifier by 3 and that'll happen. Yep. But the implication of tongue posture is really where this is all coming from. Yeah.
Okay.
So I would have had to tell my younger version of myself to get rid of it earlier too. It's just,
we evolve and learn.
Yeah.
And there's things that we didn't know, and now we do. And so parents, listen up.
yes. I'm sorry.
Yeah.
And then,
But it really, the long-term implications of that are huge.
They're huge. And so if you, when you're looking at those sleepless nights, I get it. I know, I hear parents, right? Yeah. It's not an easy time at all, but you're just trying to prevent downstream issues.
Yeah.
Yeah. And then with younger kids, we're really asking, you tell me, like, I just recently heard it on a podcast that it's like you have this window between 6 and 9 months where you really want them to almost gag on little bits of food so that way they learn a reflex of spitting things up. Is that accurate?
Well, I mean, I think that there's a certain amount of, it's a learning process, learning to eat textured foods.
Yeah.
And so if you put a textured food into the mouth of a 2-month-old,
sure,
it's not going to go well. They're not going to know what to do with it.
Sure.
But there's a certain amount of gagging and learning.
Yeah.
Not choking because you're not giving them anything big enough to block their airway.
Yeah.
But there's a certain amount of gagging that is just inherent in the process that has to happen.
Yeah.
And then they learn how to handle it.
So I think sometimes families are just worried, right?
Yes,
like
very much so.
Yeah, with my youngest daughter, she was a super picky eater, so I blended a lot of things for her because I wanted the nutrition aspect. But at the end of the day, that chewing is so valuable. It was interesting. I've done some dental missions, and my most recent one was in Cambodia, and these kids have huge arches. Huge broad arches. They're teeny tiny kids because they're not eating processed foods. They don't have the same diet that we do.
Yeah. So they have to chew everything, and
they have a lot of cavities because they're chewing on sugarcane, but sugarcane is super fibrous and tough. So they have these big broad arches, but lots of cavities.
Okay.
Yeah.
So they could chew on something else besides sugarcane.
Yeah. Yeah. Exactly.
Don't get your kids sugarcane.
No. Please don't give sugarcane.
Okay.
But we want to encourage less purees, more tenacious foods that they have to kind of work on and pull off of a bone if they can, obviously with your recommendations and advice.
Sure, but yeah.
Yeah.
Okay.
So I think that we're trying to get them away from the yogurt pouches and anything that they have to suck on.
Yeah. So many parents give their kids pouches because they think, okay, we're getting vegetables into them.
Right.
That's vegetables good.
Yeah.
But chewing more important.
Yeah.
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 And then looking at sleep for older kids, noisy breathing, pausing, waking up, those are all things we reviewed already.
For sure.
Those are all red flags that something needs to be done.
Like children in general, I mean, there's obviously a whole component for older kids as far as like iPads and screen time and all of that factors in also in terms of their going to bed.
Yeah, we talked about that last episode.
Yes. So that definitely is its own beast. But, children, if they're well rested, they should wake up and not be grumpy. Mm-hmm. Right?
Right.
Like we don't think parents will say like, oh, she's not a morning person, but is it that she's not a morning person or she just didn't get the sleep that she really deserved last night? Yeah. And it's not, parents we're doing our best, but if we're just trying to help educate families to know sort of things to look out for.
Absolutely.
So that your child can be, again, the best version of themselves, and they're not just surviving, but they're really thriving.
So you're in, just to give you the plug, the Flourish program.
You. Yes.
You're in Danville in
Yes.
Blackhawk.
Yep.
And you have your Danville pediatric dentistry. And then you have an orthodontic practice too that
Yep.
Dr. Ream
Yes, exactly.
head of, and then this Flourish program.
Yeah.
So you're easy to get a hold of. I'll have all the information on the Facebook page when we're done with this. But anything that we haven't touched on that you think we need to jump into?
I just think that for kiddos that parents, they've seen ENT, I think, again, it's a very collaborative process. So sometimes we really want to start expansion because we know dental-facially, craniofacially, they need it.
Yeah.
But we want to be mindful of a child. So if they can't breathe really well, sometimes we're going to ask that they see ENT first. Sometimes they can tolerate it and we can start expansion. But again, knowing that ENT may still need to be involved.
So if you have a kid with big adenoids and they have the high arch palate, and it's possible that the adenoid obstruction has been causing the mouth breathing, etc.
Correct.
So you fix the adenoid problem. Does the rest of it then fix itself, or do they? Because at this point now they still need to get the palate looked at and expanded because that's already happened.
Correct.
Yeah.
If they're 3 years old or so, unfortunately, if it's narrow enough, it's not going to resolve itself. Certainly, if a child is too young to be able to tolerate an expander, we start with a myomunchie. It's just a little myofunctional tool that gets them chewing, working on nasal breathing, proper tongue swallow, lip seal. There's a lot of games that the myofunctional therapists or SLPs can teach them, just blowing balloons. So there's a lot of things that we can do as we wait to get ready for expansion, but expansion, they tolerate it so well.
That's the thing I think that also kind of harkening back to the sleep episode I did. Yeah. A lot of times the impediment to the intervention that's going to help the kid isn't the kid not tolerating it at all. It's the parents somehow taking on that stress and feeling like, oh, my kid's never going to do this.
Yeah.
And they tolerate it great.
No, they tolerate it great.
And especially when all of a sudden they can breathe more easily. But even early on, before they see the benefit, they don't mind having an expander in. It doesn't bug them.
You would be, I'm honestly, I pinch myself at how lucky I feel because these kids, they're excited about a color in their mouth, even though they can't even see the color once it's in. They're excited about it. They feel really big, putting a star on their chart. It is mind-blowing. And then they start to feel better.
Yeah.
And so the parents, what I love is when I hear, oh my gosh, even if they get sick, they're not sick for as long.
Yeah.
These are really cool
huge.
things to hear.
Yeah.
I feel that they are a nicer kid the next day because they've gotten better sleep. And again, this is not to say that it's just my end. It's a team process.
Yeah, the whole thing.
Right?
Yeah.
There's a lot of people involved, but it is really impactful in a young kid. And I really feel super lucky that I get to do it.
Well, that's great.
Yeah. Thank you so much.
So, Dr. Ozzie, thank you so much for meeting. Every time I do this, I learn so much, and this has been no exception. I've learned so many different things. I have to change up a little bit what I tell people now, and hopefully my patients will listen to this. But it's just amazing. So thanks for taking the time and showing me your amazing office. And
thank you for having me. I really appreciate it.
My pleasure.
Yeah, we loved working with you over the years, and patients and families in Danville are very lucky to have you.
Well, ditto to you.
Thank you. Thank you.
All right. Wow, another great show. As always, I learned so much about a topic that I thought I already had a deep knowledge base of. But there's always more to learn, both as a healthcare provider as well as a parent or other caretaker of children. I hope listeners enjoyed and learned from the topic as much as I did. I would like to once again thank Dr. Ozzie for welcoming me to her office to take a tour and to learn about airway expansion and why having a resistance-free airway is so important from an early age in childhood. I think our discussion gave listeners a pretty good idea about what to look for in their children and what parents can do to help prevent the need for intervention by being proactive in encouraging nose breathing as early as infancy. I'm looking forward to our next upcoming episode, which will be in both audio and video formats, where we explore the topic of food allergies and what can be done to reduce or even eliminate them in children. Until then, this is your host, Drew Nash, wishing you health, happiness, and as always, a good restorative night's sleep. The opinions and beliefs expressed on the owner's manual are that of myself, Dr. Nash, and my guests, and do not necessarily represent those of sponsors or other governing boards. The owner's manual is recorded and produced at Neutron Sound in Danville, California. The content of the owner's manual is the intellectual property of Andrew L. Nash, MD, and One-to-One Pediatrics Incorporated. Copyright 2026. All rights reserved.